Hey guys, welcome to this video. This is going to help podiatry students prepare for their residency interviews. Part of your residency interview process is what they call the case study workup. So in some programs, they'll sit you down and say, hey, let's go over a case study. It could be an ankle fracture, gas gangrene, Lisfranc fracture, calcaneal fracture. But one of the most common ones is going to be the diabetic foot ulcer. This is kind of like your bread and butter, so you have to really know how to work this up inside and out. I do want to make one thing clear though. This video is not meant to be a treatment plan or a treatment algorithm. If you're a resident on call and you get paged for a diabetic foot ulcer, always speak to your chief residents and of course your attendings. Please do not watch this video and think that every single foot ulcer is treated this exact way. So let's get started. The way they're typically going to present this is they'll say, hey, you're the resident on call, it's 2 a.m., 3 a.m., and the emergency room pages you and says, hey podiatry, can you come down and take a look at this patient? He's got diabetic foot ulcer. So I'm going to tell you kind of how to work from the beginning all the way till the end, how to deal with these. The first thing you can do is when you're on the phone with the emergency room is say, hey, can I get some labs and some tests? So what are you going to order? You're going to ask for CBC, BNP, INR, albumin, ESR, CRP, A1C, EKG, and an X-ray. Now I'm going to go over each one and specifically what you're looking for. So when you say CBC, the person interviewing you will say, well, since you asked, what specifically are you looking for in your CBC? So you're going to say my white count, but you have to mention a left shift. You absolutely must mention that. So when you say I'm looking for my white count to see if it's elevated for leukocytosis, you have to mention that I'm looking for a left shift. That's number one. Number two, part of your CBC is your H&H and also your platelets. So if you have a low H&H and low platelets and you have anemia or thrombocytopenia, there might be a reason you want to transfuse the patient. So always look out for those pertinent labs. In your BNP, you're of course looking for your electrolytes, any anion gap. Is this person hyponatremic, hyperkalemic? What's the glucose level? Don't be surprised that oftentimes a lot of these diabetic patients, the first time they come to the emergency room, they'll have a glucose level of like 450, 500, 600, even 700. That's something you want to keep in mind. Another thing you want to look at is your BUN and creatinine. A lot of these patients will actually have elevated creatinine and actually have an AKI or acute kidney injury. So that's also something you want to keep in mind for your BNP. Your INRs, test your coagulation. You want to see if the person's INR is within normal limits, PT, PTT. Albumin is something I like to order personally because it really gives you an idea of the person's nutritional status. So when you're talking about foot ulcers and the healing potential, one of the main things that's stressed is vascular supply, but it's also equally important to know the person's nutritional status. What if this person has low protein and low nutrition and can't even heal that ulcer? So that's something I always order. Another test that you're going to order is, or you're going to say you want to order, are the acute phase reactants, which are ESR and CRP. And I can almost guarantee you, the moment you say ESR and CRP, they will ask you what's the difference because they're both acute phase reactants. ESR, I'm going to give you some brief overview between both of them. The ESR, one thing you want to know about it is that it generally takes longer to elevate and it also takes longer to go down after an infection. So again, you could have an infection, your ESR can stay normal for up to a couple of days or a week, and then it'll go up. And then your infection will resolve, and then it will still stay elevated for about a week or two. So that's the one thing you want to know about ESR. Number two is that it's essentially a surrogate for fibrinogen, which tests your aggregation between your erythrocytes. So that's really what you're measuring. So why is that important? Because they might ask you this question, in what condition or types of conditions can you have a normal ESR in the setting of an infection? And so you might think to yourself, well, if you know what the ESR is, it tests your aggregation of your erythrocytes. Well, what if your erythrocytes cannot aggregate normally? And one of the diseases that you want to think about is your sickle cell anemia. So that's a question they might ask you to see how you think on the spot. Another thing about the ESR is that it's not specific. The CRP is not specific either, and neither is the ESR. It could be elevated in a number of other conditions, like renal disease. It could be elevated in obesity, also in women it can be elevated, and in the elderly age. So it could be elevated for a number of reasons. So you don't look at the ESR specifically and say, oh, it's elevated, it must be an infection, or it's not elevated, there must not be an infection. The CRP is something that oftentimes we'll give more credence to. And the reason is because it elevates and falls very rapidly. So when it elevates really quickly, you're thinking, okay, this person probably has some acute inflammatory infectious process going on. And when it goes down very quickly, you're thinking, okay, the antibiotics and my treatment plan is working, so let's continue with this course of treatment. Also really important in diabetic patients is always get an A1C. You want to make sure your patient's A1C is well controlled. If it's a 10, 11, 12, I see 13 and 14, you might consider getting an endocrinology consult while the person is in-house. Also, it's always good to get an EKG for these patients. Like I said, they could be hyperkalemic, hypokalemic, have electrolyte imbalances, maybe they have tachycardia, bradycardia, ST elevation or depression. They have all these things going on, so you always want to get an EKG. And then X-ray. The main thing you're going to say when you ask for an X-ray during your interview, they're going to say, what are you looking for? And you're going to say signs of OM or osteomyelitis. And also, you want to rule out gas. You always want to rule out gas in any ulcer. God forbid you miss that. I put this in start broad spectrum IV antibiotics because depending on the program and the hospital, sometimes they will and sometimes they won't. So if you say start broad spectrum IV antibiotics, you're not necessarily wrong. But if during your interview the person says, well, in what scenario would I not want to start broad spectrum IV antibiotics? Because a lot of people will not automatically start IV antibiotics for a diabetic foot ulcer. And the reason is because if you start broad spectrum IV antibiotics, you could actually get a false negative on your bone biopsy if you're ruling out osteomyelitis. Now, osteomyelitis is a whole different ballgame. I hope to make a separate video on osteomyelitis, but I put this in stars just for that reason, because you might have a program where they start IV antibiotics, you might have a program where they don't. And if they don't start IV antibiotics, at least you know the theory of why they don't start it, so you can sound like you know what you're talking about when you say, you know what, maybe I wouldn't start it because I might think about taking this patient to the OR for a bone biopsy, and I don't want to get a false negative. In which case, they'll probably agree with you. Now, so that's all going to happen before you even go down to see the patient. You get your labs, you get your x-rays, and like I said, maybe, maybe not, IV antibiotics, broad spectrum. So now, you're going to actually go down and see the patient. First thing you're going to get, or at least what I do, is I get a past medical history. Hey, besides diabetes, any other medical conditions, hypertension, hyperlipidemia, COPD, asthma, and you also want to ask, are these controlled or not controlled? Because a person might have asthma but it's really well controlled. Or a person might have asthma and it's very, very poorly controlled and gets exacerbations and is on prednisone, which can happen. You also want to get a past surgical history. Hey, do you have a pacemaker? Have you ever had an open heart surgery? Have you ever had a bypass or angiogram, angioplasties? All these things are very important. Always get allergies. And then you get your actual HPI. Hey sir or ma'am, can you tell me, how long have you had this ulcer? When did it start? Have you seen another physician for this in the past? And then you want to say, like, have you treated this yourself? Has somebody else treated this? Things like that are very important to know. Don't be surprised when sometimes you have patients in real life where they'll say, I honestly have no idea how long I've had this ulcer. Until I was watching TV one day and my son came in the living room and said, hey dad, I see blood on your socks. That happens all the time because you have neuropathic patients who have cuts on their feet and they don't realize it. So sometimes when you part your HPI, the patient might say, you know what doc, I really don't know. In other cases, they might say, I've had it for about 4 months, I tried treating it on my own, I cleaned it with some alcohol, some peroxide at home, I soaked my foot in Epsom salt, I thought it would get better, but it didn't, so I decided to come into the ED. So you get a whole wide range of patients in their HPIs. And then you'll do your physical exam. Check vascular status, palpable pulses, CFT, skin turgor, is there hair growth, do you see hemosiderin deposits in the legs, do you see signs of venous insufficiency. Also, neurostatus, is this patient neuropathic, can this patient even feel what you're doing, does this patient have any pain? in your musculoskeletal exam, you will look for any biomechanical deformities. That's something I always do. Depending on the location of the ulcer, I say, well, this person has a hallux limitus, which is probably what's causing this type of ulceration. Or this person has a flat foot. Maybe that's why this person has this type of ulceration. Does a person have a Charcot foot? That's also something important you want to look out for. You also want to describe the wound. How big is it? Where is it located? Does it probe deep to bone? Does it probe to the joint capsule? Does it probe to tendon? Are there exposed ligaments? Is there exposed muscle? Is there a malodor? How are the wound edges? Is it peri-wound hyperkeratoses or macerations? Is there undermining of the wound edge? Does it probe deep? Do we have sinus tracts? Is there bogginess, crepitus, fluctuance? When I squeeze it, does any pus come out? Does it elicit pain? Now, pain is kind of subjective because, like I said, some of these patients are very neuropathic, so you can squeeze their foot to see if you can express any pus and they'll experience no pain. Whereas other patients will feel extreme pain. So pain is kind of subjective, but it's still something you want to see. And then finally, you take a wound culture. When you take a wound culture, you don't just simply take the culture swab and stick it in the wound. You want to clean the wound first, debride it, flush it, and then go down to the base and then take your wound culture from there so you don't get contaminants and get false positives on your wound culture results. You also want to ask the patient about the social situation. Does this patient smoke, use illicit drugs, alcohol? Where does this patient live? Does this patient live in a shelter? Does this patient live at home? Does the patient have help at home? All these factors really matter when you're taking care of a patient and thinking about the discharge part of it, which we'll get to later on. And then the third thing is, for the sake of this interview, you're going to admit the patient. So you're going to admit the patient like you would go under medicine. And then while the patient is admitted, there's a few things you want to do, a few more tests you want to order that they're not necessarily going to do in the ED. Number one is you get an MRI if you can. If you cannot, at least get a bone scan. And that's to rule out osteomyelitis. So that's number one, get an MRI or a bone scan if MRI is not possible. Get an ID consult pending the wound culture results. You also want to order vascular studies like your ABI and your PVRs. Now, there's a debate amongst podiatrists. Do you get a vascular clearance if you're going to take this patient to the OR for a debridement? One group will say, if I have a normal physical exam, like pulpoposis, no signs of arterial or venous insufficiency, no edema, no hemosiderin deposits, nothing like that, hair growth is present to the digits, ABI, PVRs are normal, I will not order or ask for a vascular clearance prior to taking this patient to the OR. There's another group that will say, you know what, any diabetic foot ulcer I have, any diabetic patient, or even a venous stasis ulcer, which is a separate video, they will always say, I want vascular clearance prior to going to the OR. Part of it is defensive medicine, so part of it is just in case you miss something that the specialist can pick up on. So if you say, I want vascular studies and a vascular clearance, you're not going to be wrong if you say you want the clearance, and you're also not wrong if you don't ask for the clearance, as long as you can justify your position. It's probably safer to just say, let me get a vascular clearance. It doesn't hurt to get a clearance. Also, when the patient is in-house, you get a PT consult. That's pretty much standard. And then before discharge, oftentimes you get social work. And this goes back to what we talked about earlier. What if this patient lives in a shelter and says, hey, I only have 48 hours and then I have to leave the hospital. If you're going to keep me longer, then I need placement after I get discharged. So whether it's a nursing home or a subacute rehab or some type of facility. So always get social work. And that's something the medicine team will do anyway, but you have to mention that during your interview. Finally, the patient gets discharged, is sent home, or a nursing home, wherever, SAR facility. The patient will follow up in clinic. And one thing that we do for all of our patients is get them some type of DME product. Whether that's offloading shoes, diabetic shoes, get them a wedge, offloading wedges, whatever you need to offload the area to prevent a reulceration. So that's the basics of your interview for a diabetic foot ulcer. This is, again, meant to just help podiatry students prepare for the interviews. Please do not watch this and say, I'm going to treat all my diabetic patients this way.